Hello, everyone, and welcome to today's Michael J. Fox Foundation webinar. I'm Dave Iverson, contributing editor at the Foundation and the host of this continuing series of webinars on topics that have to do with living with Parkinson's disease. We welcome you to our conversation today to what I think is probably the most intriguingly titled webinar we've ever done, Screening for Parkinson's with Dogs and Keyboards. We'll explain more of that in just a moment, but as always, you'll be able to submit your questions during the hour. You'll see a Q&A box in the middle of the screen, and so you can type in your questions there, and then we'll do our best, as always, to get to as many of those questions as we can, specifically focusing on that in the second half of our webinar. And then, as always, we're also providing the slides from today's webinar for download. You'll see a box called Resource List on your screen, and so you can click on that. And then that document will open up in a new browser window, and you can either save them or print them from there. All right, let's get started with our topic today and focus on what we're going to be covering. We're really going to talk more about how we screen for Parkinson's disease, both how we go about doing that now, both in terms of what might be warning signs and risk factors for Parkinson's, but also how the actual diagnosis is currently made. But then we're going to really focus on why detecting Parkinson's at an earlier time would be particularly helpful, obviously for those living with Parkinson's who might be receiving that diagnosis, but also how that could further research. And then we'll spend the balance of our time really looking at new approaches and new technologies, some very intriguing possibilities out there that would help us potentially detect Parkinson's disease much more expeditiously than we currently do. All right, let me introduce who's joining us for today's discussion. Joel Grace is joining us from upstate New York. He was diagnosed with Parkinson's in 2013, and he is very active in both participating in research and advocating on behalf of Parkinson's disease research. Joel, welcome. Thanks for being part of our conversation today.
Well, thank you.
Joining us as well is Dr. Mark Barron. Dr. Barron is director of the Parkinson's and Movement Disorders Center at Virginia Commonwealth University, and he's also leads of the Parkinson's Disease Research, Education, and Clinical Center at the VA in Richmond, Virginia, where he has conducted much of his research as well. Dr. Barron, welcome.
Thank you.
And finally, Dr. Samantha Hutton joins us as well. Dr. Hutton is Senior Associate Director of Research Programs at the Michael J. Fox Foundation, has a particular interest in this area of early screening and diagnosis, and is monitoring and supporting many of those research efforts around the country. Samantha Hutton, welcome to you as well.
Thanks, Dave.
Okay, let's get started and talk some about what we currently are able to detect about the presence of Parkinson's, both in terms of how it eventually appears, of course, when a trembling finger or a shuffling step might land you in a neurologist's office. But prior to that, we want to talk first some about some of the early risk factors and signs that could potentially lead to the presence of Parkinson's or put someone at risk for Parkinson's. And Dr. Barron, we see on the screen a number of things, many of which we're familiar with, like so many people with Parkinson's lose their sense of smell. That may be a warning sign. But let's start with what's at the top, because one of the things that's interesting about these different risk factors is that some are much more predictive than others. Some put you at much higher risk than others. And right at the top of that list, we see REM Sleep Behavior disorder. Describe, if you would, Dr. Barron, first what that is briefly, and what we know about the risk that puts someone at for later being diagnosed with Parkinson's.
Okay, so REM sleep behavior, normally when we go into our dream sleep, our REM sleep, we shut down, we don't move. But what happens with many people that develop Parkinson's disease is they don't shut down. They actually move. They can flail their arms. It can be so violent they fall on the floor. And that probably occurs in at least 50% of people that have Parkinson's disease. On the other hand, if you have REM sleep behavior disorder. It typically will start well before your first motor outward tremor or slowness. And in fact, it's been reported to start perhaps an average of even 12 years before. And by average, meaning that there are many people that may be starting 20 years before acting out in their sleep. What's intriguing for that is that that tells us that the disorder is starting in our brains way before we show up in a physician's office. So it's certainly, and as far as the prediction, so if you develop REM behavior disorder, but you don't have active Parkinson's disease, your chances of developing the Parkinson's disease may be as high as 60% and possibly even higher that you will go on to get it. So it's quite predictive, but not specific.
And I would think then that would mean, Dr. Barron, that if we can learn more about those individuals who have REM sleep behavior disorder, perhaps we could tease out even further then ways of predicting who might get Parkinson's, that they're a particularly, I guess, rich population, so to speak, for determining early signals of Parkinson's? Yeah,
absolutely. If we could look at and tell which of the people are going to get it and not going to get it, that could be a very useful screen or participating screen, since it alone won't answer the question.
But then conversely, loss of sense of smell, again, I know that's often associated with Parkinson's, shows up often before motor symptoms, but there are lots of reasons why one could lose their sense of smell. So is it less predictive than REM behavior disorder?
Okay, and it sounds like you're asking me. So
yes, sorry,
as far as sense of smell, it's certainly less sensitive than their, well, it itself, many people will lose smell that don't develop Parkinson's disease. So by itself, it's not particularly sensitive, but it could be a clue to initiate other tests to see if you're at a risk. So certainly if you've lost your sense of smell, and then we did a sleep study and found the REM behavior disorder, that combined wouldn't prove you're going to get Parkinson's disease, but would make it much higher.
And then similarly with genetic mutations, Dr. Barron, the ones that we see listed are some of the more common, LRRK2 and particularly the most common of the genetic mutations that can lead to Parkinson's. One thing that's important to know probably is there's great variation within these genetic mutations. So some put you at higher risk than others. As we're discussing this, it becomes clear, I think, that not all risk factors were created equal, right? So there's variation within these as well.
Yeah, absolutely. If you take the first one, the GBA mutation, that one, if you have that, your chances would be roughly 10%. So it's actually quite low. So if you had a medication that was going to slow down Parkinson's disease, but it was aggressive medication, you might be reluctant to consider the medication if your chances was only 10%, unless you had some other features. For example, if you had the REM behavior disorder and the GBA mutation, you would be more inclined to consider a treatment, even if it was an aggressive medication.
And then finally, on this particular set of risk factors or early signs, we have the dopamine loss, which can show up on a particular kind of brain scan called a DAT scan, and you see the visual image there. It's more confirmatory, as I understand it, Dr. Barron, than actually yet diagnostic. We still don't have a definitive imaging technique. Is that correct? That can diagnose? This is more something that seals the deal than is necessarily purely diagnostic on its own?
Yeah, there's many problems with DAT scans. Ideally, it could be literally a perfect test. It is, forgetting the expense, there's problems with it. So it's highly variable on the person reading it, whether they can read it right. It's debated how, even if it's read right and I should say done right, how accurate it is. It can be very useful, but there's many factors. There's many medicines that interact with the results of the test. So you might be on a medicine and that might not have been accounted for, and it could lead someone in a certain direction, as in the wrong direction even. So it's a very useful test if done in the right hands, but it's definitely far from perfect. But combined with other tests, it can be very useful, especially.
So we get a sense, I think, that there are indicators, there are risk signs, there are tests that can help us, but none of them completely definitive, and with the exception of REM sleep behavior disorder, none that necessarily would give us an early warning sign that would be obvious, at least early on. Right now, of course, people wind up going to see a neurologist like Dr. Barron when some of the motor symptoms appear. So let me bring Joel Grace into our conversation here at this point, just to get a sense, Joel, of what it was that triggered your decision to go in and seek diagnosis. Was it one of the things that we're seeing on the screen, tremor, slowness of movement? What was it that put you into a situation where you thought you needed to get this checked out?
Yes, this is back in winter of 2012. I'd be sitting at the computer with my left hand resting maybe on the keyboard. On some occasions, I'd notice a tremor of my left hand index finger. And that was all. It was just, functionally, it had no consequence for me. It was just kind of a nuisance. But so when I went to see my primary, on another matter, I happened to mention that, and he said that it might be an indication of Parkinson's disease, which tweaked my interest in Parkinson's disease.
Right, and you, indeed, sorry to interrupt, Joel, and of course this also not only furthered your interest, but furthered your advocacy and involvement in Parkinson's research, and we'll hear a little bit more about that later, some of the research that you've been engaged in. But I guess the key point here is, and it's something I think most people now are familiar with in Parkinson's, but Dr. Barron, as you were noting before, there were changes that were going on, not only in Joel, but any of us who have received that diagnosis long before that trembling finger became a nuisance on the keyboard, right? So do we have a sense of how long before? Is it a decade before that these changes are going on?
I would predict at least a couple decades that it's starting. I mean, it's not inconceivable that changes may even be occurring in some people as early as birth, but certainly much before, and it could be certainly at least decades.
Which puts, of course, a great deal of priority on trying to get at this sooner. So let's talk about some of that, about the way in which it would be so helpful to get a better screening device for Parkinson's disease. And we see some of those reasons on the screen, from cutting time to get to an earlier diagnosis, quicker diagnosis, treating symptoms more quickly, and of course, if we can figure out a way to slow and stop progression of Parkinson's disease, the earlier we can do that, the better. And so, Dr. Samantha Hutton at the Michael J. Fox Foundation, just give us a kind of overview, if you would, on the importance then that the foundation itself places on this. There's a lot of money that the foundation puts into research, but how key is it from a research standpoint, from the foundation standpoint, to really focus on this question of early diagnosis?
Sure, Dave. I mean, I think there's a couple points here. The first one, I think, is taking into account the patient perspective. So I think we've already touched on this, but the way we do diagnose Parkinson's disease today is very similar to what we were doing 200 years ago with Dr. Parkinson's, the touching nose, tapping thumb and forefinger. These are all very subjective assessments. And we don't have a blood test or brain scan right now that can definitively tell us objectively whether someone has Parkinson's disease. Some of these early symptoms that we're talking about may not be screaming Parkinson's to someone who's not trained in movement disorders. But as we've mentioned, by the time someone is diagnosed with Parkinson's disease, the disease is already well underway, and a person may have already lost 80% of their particular brain cells that are affected. So early diagnosis is critical to avoid some of the frustration and cost of misdiagnosis, and to enable faster access to the right kind of care. So earlier, more efficient diagnosis would mean that there are potentially more brain cells to save sooner in the disease. But it's also really, really essential for research because earlier, more definitive diagnosis would actually enable testing of therapies early on in the disease course, ideally even before symptoms appear. So patients who are in the early stages of Parkinson's are actually the target population for most treatments that are aimed at slowing or stopping disease progression. But in addition, it's really important to make sure that the people we're observing and partnering with to test new therapies in clinical trials truly have Parkinson's disease, because if we are testing a drug for Parkinson's disease and some of the participants have actually been misdiagnosed or don't have Parkinson's, we wouldn't necessarily get an accurate picture of whether the drug is working in that target population. So being able to accurately identify patients with Parkinson's disease for clinical trials specifically gives that trial the greatest likelihood for success, thereby cutting time and costs. But I think it's important to remember that the same tools that we're using for diagnosis are also used in clinical trials to track disease progression and determine whether a drug is helping to alleviate Parkinson's disease symptoms. So these tools are really important for all aspects of research into potential treatments.
It's such a good point, because so often now we are less sure of our diagnostic certainty, and so we may wind up testing therapies on people that don't actually have Parkinson's disease. And to put this in some perspective, I think it's sometimes said, and Dr. Barron, you can comment on this, that even the top of the line movement disorder specialists, people like you and your colleagues, sometimes miss it, right? Because it's based purely on clinical observation, and there are a lot of things that can look like Parkinson's that may not be. So is that a fair assessment, that even the best neurologists might be right 8 or 9 times out of 10? That's good, but it does indicate that there's still error in diagnosis being made. Is that a fair assessment?
Yes, absolutely. Studies show that even in the best hands, the accuracy may be only 85–90%, especially at a first diagnosis, at a first visit.
So I want to take a couple of questions. We're about to transition into some of the really new and interesting ways in which we can screen and diagnose Parkinson's. But a couple of questions that have already come up that I think we should try to respond to. Starting with one on REM sleep disorder behavior, because we indicated that was something that was such an indicator. And one person wrote in, so how do you go about actually diagnosing REM sleep behavior disorder versus other sleep problems like sleep apnea? Can you just comment on that briefly, Dr. Barron, how you make a REM sleep behavior disorder diagnosis?
Well, you can make a presumptive diagnosis just based on the history, but to definitively diagnose it, you need to do a sleep study. So when we go into REM behavior sleep, with what your eyes actually move, so it's rapid eye movement sleep. So you can put a little superficial monitor near the eye and see that the eyes are actually moving. And during that time, if you put a similar monitor on the limbs, you'll see that the limbs are also moving. And it won't be all the time, but during some of the REM sleep. So again, when we go into REM sleep, our eyes will be moving, but the limb monitor should be absolutely silent. But people with REM behavior disorder, both will be moving at the same time. So there's very strict criteria, and it's pretty easy to diagnose with a sleep study.
And here's a really straightforward question from Kevin, which is, what's the point of early screening of Parkinson's if it can't yet be stopped or reversed? Samantha Hutton, why don't you respond to that first? You were making part of the argument just a moment ago that one of the real values of it is that it allows us to be more certain, it would allow us to be more certain of diagnosis so that we can appropriately and accurately test new therapies. But how else would you respond to Kevin, that how much point is there in this since you can't yet reverse the disease?
Yeah, right, Dave. I mean, you hit the nail on the head. So biomarkers don't just assist in diagnosis to tell who has Parkinson's disease and who doesn't. They can help clinicians track disease progression over time. So being able to diagnose people with Parkinson's objectively helps in clinical care. It helps for the diagnosis, but it also helps with treatment regimens. It helps to know whether a particular subset of patients may benefit more or less from a particular drug treatment. So it can actually be used in clinical trials for the enrollment process to make sure, again, that we're getting the right people in those trials to know whether or not the drugs are working. And like I said, they can be used in clinical trials as outcome measures to determine efficacy. So then we can know whether the drugs that we're testing are actually working with a very objective test that will give us a yes or no answer of whether the drug is moving the dial and helping with some of those symptoms.
And Jill, Grace, I would think also it's important to know early on for two reasons, not only getting good treatment, as Samantha was just discussing, but engaging more in exercise, which we know is helpful, and engaging and participating in research. I mean, one of the first things you did after diagnosis, and could have done sooner if you'd been screened earlier, was to get involved in research. And the earlier we can get people engaged in research, the more we can learn. And that's something I know, Joel, that you've taken particularly seriously.
Absolutely. I was diagnosed in February of 2013, and by the end of the month, I was here at the University of Rochester for a screening trial for Parkinson's Progression Markers Initiative, or PPMI. And to me, I have a research background, so for me, research is synonymous with hope. And I wanted to get in there and put up a fight. So I became an advocate for research, and I did get into the PPMI study, and I'm still in it. It's a long-term study,
Which is
5 years.
Right, which is a great contribution. And Kevin, who raised the question, what's the point of early screening if you can't reverse it? Thanks for raising it. It's a really straightforward, important question, and I hope that provides some sense of why this is really important going forward. All right, let's move into some of these really new and interesting ways in which Parkinson's might be detected at an earlier date. And we see these really interesting combination of possibilities here, everything from scent to voice changes, eye movement, breath compounds, and the like. And so we're just going to work our way through a number of these, and we welcome your questions about any of them as we go forward. Samantha Hutton, why don't you take up the one involving both scent, and then we'll get to breath compounds, because in some ways they're a bit related. But the scent thing got a lot of attention, I think a year ago or so, with the story out of Scotland that there was a woman who could apparently smell Parkinson's, that in a series of tests she was able to correctly identify people who had Parkinson's basically based on her sense of smell. It sounds fanciful. It sounds like, well, how could that possibly have any science behind it? But there may actually be. Tell us a little bit more about what we're trying to learn about that, and why we think that might be a useful thing to pursue.
Sure, Dave. Yeah, that was a really exciting story. I think it was in 2015. And the Fox Foundation is following up on this really exciting finding by actually working directly with that woman who has the super sensitive smell and others to really see whether this holds up in a larger number of Parkinson's disease patients. So we're going to be testing that in larger volumes of people to see whether it holds up. But excitingly, we're also funding research to train dogs to potentially be able to sniff out Parkinson's disease. dogs are used for bomb sniffing, they're used for cancer sniffing, so really trying to see if we can train dogs to sniff out Parkinson's disease. And there's also some rodent work, some work in mice as well. In parallel, research is underway to determine if there is a particular odor secreted from the skin of Parkinson's patients, whether the chemical composition of these particular secretions can actually be identified. So scientists are collecting these secretion samples from Parkinson's patients and healthy people and using them to develop a sort of electronic nose technology that can actually detect the specific Parkinson's disease chemical signature. So ultimately, this would be a non-invasive technology. You can imagine almost holding it up to the skin and getting a readout of the particular chemicals that are or molecules that are being secreted from somebody with Parkinson's disease, and then using it as a way to determine or diagnose or test for Parkinson's, which is really cool.
No, it's fascinating, and we know in certain other diseases like diabetes, for example, that a particular odor can be emitted by way of one's breath. So it's interesting that these possibilities are out there, and that leads me to asking you also, Samantha Hutton, about what's also on our chart here, which is breath compounds. This isn't by way of odor, I don't think, so much as sort of the chemical analysis of what someone exhales. And again, there's precedence for this in other diseases, lung cancer, I believe, in particular. But what is it that we're trying to find out in regards to what someone exhales and what that might tell us as a warning sign or a screening device for Parkinson's, Samantha?
You're exactly right, Dave. Our breath actually contains a mix of a lot of different chemicals and compounds, and there are devices which can actually collect and measure what a person exhales. So, like you said, there are examples in the cancer field, both with lung cancer and breast cancer, where there's a particular breath signature that's been identified that's unique to people with these particular diseases. And in fact, breath signature tests are actually FDA approved to monitor heart transplant patients, for example. So we're actually applying this really innovative technology to Parkinson's disease through research at Emory University in Atlanta. Scientists there are looking at breath compounds from 100 people, half of them with Parkinson's disease, half not, and determining the chemical makeup of those breath compounds to see if they can really develop, again, a signature that's unique to Parkinson's disease.
This is all so intriguing, I think, on so many levels. And Dr. Mark Barron, I wonder if you would comment on a question that's come in that I think connects to this. Lawrence writes in, how likely is it that a biomarker for Parkinson's might also be or point to a biomarker for atypical Parkinsonism? And the reason I ask the question in part at this point is that as Samantha was describing, these breath compounds, we already know, can be distinguishing for certain kinds of cancer. But it seems like we're in the process of really slicing and dicing things very finely now, that our science is advancing to where we can, in fact, identify very subtle differences in different biomarkers that might even be able to distinguish between one kind of standard garden variety Parkinson's and an atypical Parkinson's, like multiple system atrophy. This will lead us into what you focus on, eye movement, in just a moment. But can you comment on that more broadly about, are we getting to the point where we can really get very, very specific about what particular kinds of biomarkers identify?
Yeah, so from a biomarker standpoint, that word can be stretched to include invasive. Today we're mostly talking about non-invasive, but from invasive, certainly you can measure, we may be able to look at blood samples or spinal fluid samples and differentiate between these conditions. That's been worked on for some time. But still not quite sensitive enough. There's imaging techniques, which is non-invasive, that certainly are being worked on. So, for example, with Parkinson's disease, the problem or the main protein involved is alpha-synuclein. If in some of the other atypical forms, for example, PSP, in that case it's tau, that's the protein, and so there are measures of tau in the brain. And so right now these tests are not highly sensitive enough and widely available, but they may be in the future, and that we could differentiate. And so from those standpoints, yes, that those things are all being worked on very, very vigorously.
And leading that into your particular work, which has had, I think, shows so much interesting promise, and also is something where there may be something quite specific and definitive about eye movements that distinguish different kinds of conditions than another. But I'm getting a bit ahead of myself, so let me step back and ask you to describe what your research has focused on and what you're beginning to find about something very distinctive about eye movement and people who have Parkinson's disease.
Yeah, so we've been working on this for, I would say, 15 years now. We've been examining patients. We mostly have done this research at the Veterans Hospital, and more recently at the Virginia Commonwealth University. And we initially, at the VA hospital, we were examining, and still are, every single patient that walks into our movement disorder clinic. And so over the years, we've now tested over 4,000 people, approaching maybe 5,000. And what we've been finding is very signature findings that really, we feel, highly accurately differentiate between these different conditions. So people have known for years that certain conditions have certain features, but yet it's always kind of been a scientific interest. And when we started, it was also a scientific interest, but over time, as we kept doing more and more patients, it became clearer that how powerful a tool this really can be. And I would argue that each of these atypicals can be differentiated from each other and from Parkinson's disease with way higher accuracy than a clinician can do. But that's where our tests are actually, our funding through the Michael J. Fox now is actually blindly trying to actually prove that. So that must be done to prove that we're not overexcited and wrong. But certainly over the years, when we test people on their eyes and we see particular patterns that we're getting to distinguish more and more, what we're seeing really is predicting what people really have.
So describe what it is that you see, and I know you say that you see this in almost 100% of people with Parkinson's. There's a distinctive feature to their eye. What is that?
So maybe not quite 100%, but in a high proportion. And what we see is most people with Parkinson's disease have an eye tremor. So just like a tremor in the hand, you see that behind the eye. And so these aren't tremors that you can see in your clinic. It requires very, very, very sensitive equipment. So what you're seeing is if you don't have Parkinson's disease and you stare at a dot on a screen, your eye is rock still. It's not moving. But again, with these very sensitive equipment, what we see is that the eyes are oscillating. They're moving in all directions, and they're not quite still. And we see that, again, just about in everyone with Parkinson's disease.
And that tremor, that eye tremor, is something that can be detected through this sophisticated equipment that you have. But your long-term hope, as I understand it, is that that equipment could be available in perhaps even a routine eye screen, so that this would be a way, if you could, since everyone with Parkinson's, or almost everyone with Parkinson's, has this feature, that you might potentially be able to detect whether or not someone is later going to develop the more obvious symptoms of Parkinson's disease. You might be able to detect that early on. Does that eye tremor, do you think, appear much before the more standard movement questions that we associate with Parkinson's?
Yeah, so we know, because we know that people with REM behavior disorder, that a high percentage will get Parkinson's disease, we actually did a pilot study, and we looked at 24 people who have REM behavior disorder with the prediction that they won't get Parkinsons, or the ones that will, won't get it for roughly 10 years from when we originally saw them. So they were early in their diagnosis of REM behavior disorder. And when we looked for the eye tremor, we actually saw eye tremor in 60% of the people. So our thought is that we're picking up already who's probably going to get it and who's probably not. And in fact, we have followed the people as long as 6 years, and we have 2 people that actually convert, 4 people, three or four people that have now converted onto Parkinson's, and they were correctly predicted from the eye testing that they were at risk, and the longest period being 6 years. So we tested a gentleman, and 6 years later he presents now with typical symptoms of Parkinson's disease.
So to match up the math here, what's intriguing about that is if about 60% of everyone with REM behavior disorder go on to get Parkinson's, what you're saying is that about 60% of the people you tested with REM behavior disorder had this eye tremor, and potentially those 60% are the same, right? The people who have the eye tremor are the ones who will go on to develop Parkinson's. That's the hypothesis?
Correct. So what we, assuming we're right, which everything's pointing in that direction, assuming we're right, if we are right, then the question, then what it's telling us that before you would develop your first outward symptom, you would develop, in a majority of people, you would develop the eye tremor. Now, whether you would develop the eye tremor 10 years before, 20 years before, or only 6 years before, we don't know that yet. But we do have a number of people, again, who we did the eye testing on who still haven't converted, who are 6 years out. In fact, the youngest person was 27 years old, so who still hasn't converted. So, could we be picking him up 20 years before? It's highly conjectural, but it's possible. But anyway, what we're doing now through the Michael J. Fox Foundation is we're being supported in a blind fashion to really answer these questions in a much more rigorous fashion, in a blinded fashion.
But the potential, I think, is remarkably intriguing, and one that could make a real difference in terms of early screening and early diagnosis of Parkinson's disease. A couple of questions about your work are already come up, so let me get those to you, Dr. Barron, and then we're going to move on to a couple of other ideas. One question that's come up is the testing right now only going on in Virginia. Obviously, there are probably people hearing this who think, wow, I'd like to go get my eyes tested to see what's what. Are you the only place at Virginia Commonwealth University and the VA in Richmond where this sort of eye testing is going on?
Well, we're the only people that we know of who are doing it, other than as part of our Michael J. Fox study, which actually involves Iowa, University of Iowa, and Emory. So we're doing it at more than one site, but we're the only center. Actually, only our veteran center is actually using it more widely. We do have to caution that this is all research, so we would not be able to offer it to somebody who wouldn't be able to test you and use it at this point. Not till we put the proof forward and assure that we're correct.
Yeah. Okay. Let's go to a couple of other ideas, and then we'll take more of your questions. We see a couple of other things on our screen here that we want to take up as well, and bring Joel Grace back into our conversation, because you've participated in some of these tests, Joel. We see at the bottom of the screen on the right movement and activity, and what this references is in part what we can learn by wearable technology, whether these are using your phone or a smartwatch or a Fitbit or different things that we might be able to learn about Parkinson's, and whether or not that could also be something that could serve in a screening kind of capacity. Joel, what have you participated in? And then Dr. Barron, I know you have some experience or commentary on the wearable possibilities too. But first to you, Joel, what has been your experience with this?
Well, one of the studies that I participated in at the University of Rochester was called Objective PD, which was a telemetry study using an app on my smartphone. And 3 times a day, I would assess motor control, for example, finger tapping, reaction time, postural sway, and a number of things like that. In that test, I would do it varying times immediately after taking my medication, an hour, 6 hours, 12 hours. In other words, it would assess these motor changes at varying times after taking medication.
And Dr. Barron, you can see how sorry, Joel, go ahead, please. Sorry to interrupt. What else did you want to add?
I was going to say there's also there was a comparison with control. There were people without Parkinson's disease who also participated in that study.
Okay, great. Thank you. Dr. Barron, you can see how accumulating that kind of data could be really useful for a physician and for a patient to sort of be able to provide more ongoing information, more monitoring than what takes place when you just go see your neurologist twice a year for 30 minutes or whatever, that you could collect a lot more data through these wearables. I guess what's less clear to me is how that could be used as an early screening device. Can you provide any clarity on that?
Yeah, so the question is whether wearing at home would be different than, say, coming to a clinic and having fine motor testing done to see if you look different than, say, a control population. But it would give you many more opportunities to look over greater time. So it's conceivable. I could conceive it also being used to see how for example, if we used our eye testing and we determined that we're at a high risk for Parkinson's disease and we thought you were going to get it and you were enrolled in a study with a medication to see if it'll slow it down, we may be able to use motor testing to also pick up some small features that may be advancing and see if the group who's not getting the medicine, for example, look different than the group who is getting the medicine as far as these fine motor features that you may be able to monitor at home. So there's a number of utilities there.
And I would also think it could refine further your treatment regimen, right? If you can get specific data about what happens with someone like Joel was describing, if he wears this and collects data right after he takes the medication, it could give someone like you, Dr. Barron, much more data about how a particular treatment regimen is working.
Yeah, absolutely. So if you one thing that so if you change a medication, you might be able to either because someone can't describe well enough to you, the patient can't describe well enough, and so you're not sure. Someone might be describing dyskinesia, they might be describing tremor or whatever, and you may not be able to clarify in the clinic, and you may be able to send them home and alter the medicines and get a much stronger, clearer picture. And I mean, this could even all be done with highly advanced software that could really answer a lot of questions of what's going on at home and help you to tune your medicine. Is that the answer? I'm not sure, but there's certainly cases where it could be highly useful, and it may turn out that it's extremely useful.
Great. Let's pick up on our last couple, and then we'll go back to more of your questions and answers, well, your questions. Hopefully, we'll provide the answers. But Samantha Hutton, let's go back to a couple of things that I know you've been monitoring. We see on here a keyboard use. Joel Grace mentioned earlier that one of his first warning signs was that he had a trembly finger that he noticed when he was using his laptop. I had a similar experience myself. So it seems intuitive in a sense that if you were able to sort of monitor or test how people are using their keyboards, that might be give us some useful information about Parkinson's disease possibilities. But this has been a mixed experience, as I understand it. Is that right, Samantha? That we've tried to use keyboard studies, and we haven't gotten necessarily very definitive data, but you learn from that too. So tell us what we found out through those particular studies.
That's true, Dave. We have funded several studies looking at whether typing on computers or smartphones, which is something we're all doing every day, especially now, can really be used to objectively assess motor impairment in Parkinson's disease. So this typically involves typing a particular phrase, or in some cases it could just be a program that you install in a participant's home computer that really just monitors in the background their typical everyday computer typing as they go about their normal emailing and business. So one of the studies that examined the different kinds of typos that people made if they had Parkinson's disease, to see if those particular typos were different than healthy subjects. And you can imagine there's sort of a cognitive component here. This is all really appealing to have a test that could evaluate a person's risk or symptoms merely by analyzing the typing that we're all doing every day. But as you said, unfortunately, to date, it doesn't seem like the keyboard tests have really proved themselves to be more accurate or useful than some of the currently available methods. But it is possible that refining the algorithms and the data and the way we sort of analyze that typing could potentially improve their discriminatory capabilities.
And a reminder, too, I think that, on the way to finding our answer, there are inevitably failures or disappointments along the way, and that's part of research, right? That's the only way we find things out, is by studying them, asking questions, and sometimes you don't necessarily get the answers that you want, but you learn from that as well. One more, Samantha, that I know you've monitored at the Foundation, and that's voice changes. Again, this is something that I think of, at least, as being something that happens later on in Parkinson's disease, that people's voices get softer in particular. But there's some interesting work being done about trying to record people's voices early on, being able to then assess them over time with specific particular populations that are at risk for Parkinson's. Bring us up to date on what we're learning about voice as an early risk factor, perhaps.
Sure. So speech or voice is actually a very complex motor skill that requires coordination of more than 100 different muscles. And as you said, people with Parkinson's disease often do struggle with speech or abnormalities, which could be an indicator of motor dysfunction. So the Parkinson's Voice Initiative is a study that collected 17,000 voice recordings from Parkinson's patients using telephone and smartphones to show that voice changes could accurately identify people with Parkinson's disease. And now investigators in Prague are using simple speech recording and voice pattern analysis to see if they can detect voice changes in 100 at-risk subjects with this REM sleep behavior disorder that we've been talking about, which we said is one of the risk factors. So that's really exciting, and it's cool because this voice recording test is being administered in 5 different languages and could potentially be implemented over the phone. So you can imagine that this, if it is very discriminatory and is able to detect Parkinson's disease in Parkinson's subjects, and perhaps even people who will go on to develop Parkinson's disease in REM sleep behavior disorder people, this could be something that would be very easily implemented and transfer across different countries and different languages.
It's so interesting, I think. And Dr. Barron, it also makes me think of a question, which is that perhaps some of these things will work, and perhaps quite likely they will work in conjunction with each other. So there might be something where you have a population you know is at risk, and through a combination of techniques, be that eye tracking or perhaps voice analysis, that these things could work in a complementary kind of fashion to sort of complete the puzzle and leading then to a more definitive diagnosis. Does that make sense to you, that these things could work in that kind of work in combination?
Yeah, absolutely. More than one test would have to be more sensitive than one test alone. And then the other thing is that I kind of alluded to was it may be that even if you use the eye movements to diagnose, then it may be that the best test is not the eyes, but rather the voice and the progression of the voice, or the progression of the keyboard use, or some other measure that may actually, may allow us to measure progression better. And no doubt all this is huge because it is hopefully around the corner, or at least not too far out of reach to believe that we can actually have a chance of slowing down Parkinson's disease. And if we can do that, then we got to diagnose it as early as possible. And then we also have to have the best methods of knowing if our therapies are working or not. So we don't want to wait till. So if the eye detecting is picking it up 10 years before, we don't want to wait 10 years to find out if people are converting. We want to see if we're slowing the progression. And it may be that a number of these combinations can answer, is one group progressing and the other group progressing more slowly.
Terrific. Well, let's get to our remaining questions and pick up with the very comment you were just making, Dr. Berenson. Let me give this question to you. Jill writes in, so if these methods are able to diagnose Parkinson's early, what treatments are on the horizon that might slow the progression of Parkinson's disease? This is sort of the Holy Grail, of course, of Parkinson's disease research, figuring out what could slow down progression. But there's a lot of interesting things, a lot of interesting work being done in that arena right now. Can you just give us a few highlights, Dr. Barron, of what some of those possibilities are that we think have a chance, at least, of slowing down progression?
Yeah, so there are a number of genetic approaches. One of the, at least for me, the one that seems the most exciting right now is there are a number of almost immunizations that are. There's a number of studies. Michael J. Fox has been very involved in those, supporting those, and it's studies that are trying to actually remove what we think is the bad protein in the brain. So actually trying to remove alpha-synuclein, which we believe is the bad player, and trying to actually attack the protein and remove it. Those studies are extremely exciting. Too early to know what's going to happen, but extremely exciting. There's genetic studies that are trying to alter there's studies that are actually trying to alter the production of the alpha-synuclein in the brain.
And Dr. Hutton, anything else you want to draw our attention to that we'll know fairly soon? There are studies about even things like a blood pressure drug that we think has some possibility of slowing progression. There's a lot of interesting things that we'll know some answers to fairly soon, right?
Yeah, definitely, Dave. I mean, we're trying to really touch any possible avenue that we can. We don't like to put all of our eggs in one basket. So I think really being able to investigate simultaneously the protein clumping of alpha-synuclein and specific therapies that are targeted to that, like Dr. Barron mentioned, as well as the drug that you mentioned, Dave. I think we're really trying to hit it from all angles and figure out exactly what we could do to stop disease progression, because that is the Holy Grail that we're looking for.
All right, let's take a few more questions before we wrap up. Dr. Barron, some people are asking if they should start, if the goal then would be to start that medication, if we identified something that would slow progression, then as soon as some sort of definitive early screening diagnosis was made. So that's the end goal, right? To sort of screen early, identify earlier, and then get people started on something that would reduce the progression of their condition.
Yeah, absolutely. The time to start treating Parkinson's disease is before you have it, before you have your first symptom. And again, we're pretty sure that's happening at least a decade before. And so if we can identify that, then absolutely that's the time to start the medication. That's when it potentially could have the most impact, and especially to slow when you actually start showing your first symptoms. And even if it can't stop it, if it can slow down, if it can delay 5 years when you have your first symptom, for example, and then even once you develop your symptoms, if it can potentially greatly or even at all slow down the course of your disease, that's huge. So.
A couple more questions for you, Dr. Barron. One person asks, are patients aware of the eye tremor? Is that something the Parkinson's patient themselves is aware of? And related to that, someone else asks whether that eye tremor leads to vision problems.
Yeah, so no, patients really are not aware other than if the tremor is large enough. What we've actually shown is what we find is people lose what's called the GrayWhite Differentiation. So, for example, looking at a newspaper where the writing can almost turn into the background, you can lose that visual clarity. So you're not losing vision, but you're losing the differentiation between grays and whites. So we have some cards that we have people look at, and if you look at those cards, we give you a black and a white, and we make that black grayer and grayer and grayer till you can't tell the gray from the white. And people with Parkinson's disease lose the ability to differentiate the gray from the white much sooner than people who don't, and it appears to correlate very well with the size of the ocular tremor, but that's a little early. We're not quite sure of that yet, but without a doubt we're seeing that, and it seems to be correlating with the tremor itself. So,
but interestingly,
again, people are not very aware, but many people are aware of that, and many people go to even an ophthalmologist and say, my vision's not right. And then the ophthalmologist says, I can't tell you why.
Question from Brad, who says, I have Parkinson's-like symptoms. I've been to numerous neurologists and movement disorder specialists. I had a DAT scan, but it looked pretty good on both sides. The doctors are saying it's a Parkinsonism. It's frustrating, as I want to get at the cause and get started with treatments. This is sort of a classic kind of problem, right, Dr. Barron, and points to what you said is the lack of definitiveness about DAT scans, even though they can be helpful.
Yeah, DAT scan's really hard to use. I would be really cautious using the DAT scan to affect treatment, and if there's a chance it's Parkinson's disease at all, what you want to do is you want to try levodopa, because if you have Parkinson's disease and you go on levodopa, it's just about guaranteed that it will work. And if you don't have Parkinson's disease, most cases, depending what you have, in most cases it's certainly shouldn't have a major impact. But I see people all the time that I can't be 100% sure, and I will try them on levodopa just to make sure that they don't have it if I'm not totally confident in saying that.
And one last question for you, Dr. Barron, and then we'll get a closing comment from Dr. Hutton and Joel Grace as well. I know you're embarking now on this new study to see if the eye tremor can be determined as something that can be used as an early screening and diagnostic through a blinded study. How soon will that study be completed? When will you know the answers to whether or not this really can be used in the diagnostic way that you hope it can be?
Well, that's a good question. We're planning on doing an interim analysis in several months, or maybe another 3-4 months on our data. But the actual study is intended to run. It could run. It's running over time, so it may be running as long as another couple of years till we are able to really look at all the data.
Still in the pace of research, that's actually pretty quick, so that's encouraging. A last word from you, Dr. Samantha Hutton, about sort of the overall approach the foundation is taking to this question and your hopes, I guess, for how soon we will be able to make some real progress in providing more definitive ways of screening and testing for Parkinson's.
I'm really hopeful, Dave. I think the technologies that we've talked about today are some of them very early stage, out-of-the-box kind of ideas, which are really exciting and new. So we're pushing those along, but we're also looking at some more routine, blood tests. We didn't talk about the more invasive technology or applications, but I think with the combined approach that we've talked about, we really will get there soon. And I just do want to take this opportunity to thank Joel for his participation participation in research and encourage others who might be interested to get involved to visit our Fox Trial Finder website to really get involved in research, because without people that have Parkinson's and people that don't, none of this is really going to be possible. So thank you to Joel and anybody else on the line who is interested in participating and helping us along.
Good point. Thank you, Samantha. And there's information on the screen now about getting engaged in research. And Joel, a last word from you. You said something earlier that I thought was so on point when you said that research is synonymous with hope. So just a last thought from you about that, the importance of research for those of us living with Parkinson's.
Well, for me, research is actually therapeutic. It gives me a feeling of participating, gives me a feeling of, rather than being a victim, that I'm doing something that's going to help me or help others. And as I said, it makes me cope a whole lot better to know that I'm doing something positive to get us where we want to be, which is a cure for Parkinson's, and maybe even better prevention of Parkinson's in the first place. But thank you.
Well put. Yeah, thank you, Joel. Thanks very much for your presentation and for saying, I think, at the conclusion here exactly the message that we want to send out. So thank you to you. Thank you to Dr. Samantha Hutton. Thanks to Dr. Mark Barron as well. And thanks to everyone for their participation in today's webinar. We'll be sending out a link to the webinar so that you can listen again or you can share it with others. And we also want to ask you to mark your calendar for our next Third Thursday webinar, which will be on November the 16th. Where we're going to be focusing on, in some ways, this very topic, a new online research tool called Fox Insight, which is a way of capturing the information and experiences of people living with Parkinson's to further accelerate our research. That will be our focus on our Third Thursday webinar on November 16th. Until then, I'm Dave Iverson.